Hello, everybody. Welcome to the ACI Alliance Tuesday Talks. I am Nicole Weston with the ACI Alliance, and I am going to hand it over to our moderators, Kelly Flodin and Carol Halla, to get us kicked off. Thank you very much. And we do ask people to keep their cameras off and to mute themselves. Kelly, go ahead.
Welcome, everybody, to the ACI Alliance Tuesday Talk. Carol and I are going to be your co-hosts today. This webinar is being recorded. Carol and I are members of the ACI Alliance Consumer and Family Focused Advocacy Network, the CICAN. My name is Kelly Flodin. I am part of a large family with bad genetics for hearing loss, lots of hard of hearing, deaf, hearing aid wearing people in my family, and I'm the first of the gang that made the jump to cochlear implants. I was implanted bilaterally a few months apart in 2020 at MUSC in Charleston, South Carolina, a place where today's speaker spent some quality years working her magic. It's been a life-changing, amazing experience for me. It's got me back to living my life as I know it. This talk is a third in our new series for parents, adults with hearing loss, family members, and others interested in hearing loss and cochlear implants. We hope that you can learn from it and also consider getting involved in the work of the ACI Alliance.
Hi, everybody. I'm Carol Halla. I started losing my hearing as a young adult, and I grew up with normal hearing in a normal hearing family. I wore increasingly powerful hearing aids for a very long time until getting my first cochlear implant in 2010 here in Charleston at MUSC, and my second one in 2015. And I'm also an Air Force retiree. Kelly and I live actually about 10 miles apart, but believe it or not, our paths had never crossed until now. So small world, right, Kelly?
Yes, it is.
Yeah. So first, let's review the technology and go over the Zoom settings that will help you. To access live captioning, first click in the navigation panel at the top of your screen, and then under the Meetings tab, verify that live captioning is enabled. And if it's not, just click on the toggle. If you'd like to ask a question, just type it into the chat box, and you'll be good to go.
What is the ACI Alliance? We're celebrating the 10-year anniversary of our founding. The American Cochlear Implant Alliance is a unique organization that is focused on cochlear implants across the care continuum. We have over 2,000 members, clinicians, including audiologists, physicians, speech pathologists, and psychologists, and others on implant teams, the teachers of children with hearing loss, students, adults with cochlear implants, parents of children with hearing loss, and military members and veterans, and other advocates. We were started because it's felt that cochlear implants fall through the cracks at other general organizations, and we just wanted to focus attention on cochlear implant issues and gaining access to cochlear implants. The mission of the ACI Alliance is to encourage and support the research on candidacy, the broad impacts of cochlear implants on children and adults, improve delivery of cochlear implant services, and advance the awareness of the best practices to a broad audience. That's the primary care doctors and other health professionals, early interventionists, the educators, policymakers, payers, and the general public. Advocacy. We need to educate and encourage the policymakers and payers to improve access to cochlear implants.
ACI Alliance's newest advocacy network is CICAN, CI Consumer Advocacy Network for Adult Consumers and Family Members of Recipients. It's aimed at enhancing and enlarging the broader advocacy efforts with firsthand knowledge of cochlear implants. Personal stories make up the difference in positively impacting decision makers and adds credibility to our contacts with state and federal representatives. If you're interested in learning more, please let us know via the chat box. Just type in your question and your interest, and you'll be followed up with an ACI Alliance staff member shortly. Next slide.
Slide 5. We also wanted to share a few of the ACI Alliance website resources that are available. We have stories by parents, adults, recipients, and veterans, insurance information, webinars, the best practices for adults and children, the ACI Alliance blog on adult rehabilitation, and just what is a cochlear implant and steps to getting your cochlear implant.
And now we are delighted to introduce to you our featured speaker today. It's my very great pleasure to introduce to you someone who has had a huge impact on my life as my CI audiologist when she was here in Charleston, South Carolina. Meredith Holcomb, Doctor of Audiology and Certificate of Clinical Competence in Audiology, is a practicing cochlear implant audiologist with 16 years of experience. She is an associate professor and the director of the Hearing Implant Program at the University of Miami Ear Institute. She received her doctorate of audiology from the University of North Carolina at Chapel Hill, and she spent the first 13 years of her career right here at the Medical University of South Carolina as a clinical director of their cochlear implant program. She is the immediate past chair of the American Cochlear Implant Alliance Board of Directors, and she will complete her 6-year board term next month. She serves on the Joint Committee for Infant Hearing, the Audiology Advisory Council for Advanced Bionics, MED-EL, and Hemedina. She is also a faculty member for the Institute for Cochlear Implant Training Advanced Audiology course, and serves as a consultant for Cochlear Corporation and Audiology Online. Lastly, she is principal investigator for 2 research grants with Cochlear. Wow. It is my very great pleasure to introduce this very accomplished woman who has a huge heart, Meredith.
Thank you, Carol and Kelly. It's really warm and dear to my heart that I've got 2 of my South Carolina natives that are able to moderate today. And I desperately, am missing you guys all the time, even though I'm in Miami. And so just because we're far away, you're definitely still in my thoughts. I wanted to say, it was a wonderful introduction, but even with all of the long list of things that Carol so nicely pointed out that I'm involved in with cochlear implants, the one thing I am not involved in is I don't have a cochlear implant. So I'm going to try my best today to walk you through what it's like from an audiologist point of view of what we're doing in that cochlear implant programming session. But I want this to be, a conversation where I can learn from you and you can learn from me as well. So please put any of your questions in the chat. So with that, I'm going to get started. So this photo is courtesy of MED-EL. I actually really love this illustration. I think most of you probably know how a cochlear implant works at this point, but some of you may not know. And so, regardless of if the processor is here on your ear or if it's on your head with one of the button processors, the sound is being picked up by the speech processor. It's sent to the headpiece and through the skin to the internal device that was implanted by your surgeon. The sound is then sent through the internal device to the inner ear, and you can see how, if you follow the flashing light, how it's going into that snail-shaped organ, which is the inner ear. And then it's sending sound from there, from the electrode array to the hearing nerve and up to the brain. So the reason I start with this is because there's a lot of places where the sound is having to be worked through in order to get to your brain. And your brain is really the part of your auditory system that plays a huge role in how you are understanding speech with a cochlear implant. I think the primary reason most patients that I work with say that they want to get a cochlear implant is because they are wanting to communicate more with their family, with their friends. They want to be able to understand more than they could with a hearing aid. While this technology is amazing, and I truly think that it's probably the best invention of my lifetime, it's not just the technology, it's not just the implant that's doing the work. There's a lot of parts of our hearing system where things could maybe go in our favor or not go in our favor. So think about that a little bit as we go through some of the slides. I am an audiologist. I'm not a surgeon. So the difference, of course, is I'm not the one putting the device in, but I am the person that you would come to see. And Carol has spent many hours in my office with me. And I would be the one who is programming the device. A little bit about an audiologist as well. We do now all have doctoral degrees. That's the entry-level degree. There are some audiologists who still have master's degrees. That was the original degree that you had to have to be an audiologist years ago. I, in fact, am old enough that I'm the first graduating doctoral class of the University of North Carolina, which really sort of ages me, I guess. But, some people you'll see have the CCC-A after their name. Some people do not. It doesn't make you any better or any worse of an audiologist. With the alphabet soup is what I call it behind our name. What's really important for you is to find someone who truly understands you as a person, understands your family, understands your situation, and has a vested interest in wanting you to hear and understand better. And I think it takes sometimes a little bit of trial and error to find the right person. I'm still in the stages of trying to find someone to marry. So you can imagine how, Carol's laughing. You can imagine how many years I've spent trying to find the right person. So the same can be said for an audiologist as well, but it's really important that you have someone you can trust. So thinking back about the cochlear implant, with all of that being said about how the device is transmitting sound from the outside of your head all the way to your brain, there's some expectations that I think most cochlear implant recipients should have. You should be able to expect that you're going to have sound awareness and detection of sound in a borderline normal to mild hearing loss range. And remember, when I say borderline normal to mild, that's not normal, right? So we're not able to give you normal hearing with a cochlear implant, but it's as close as you can possibly get. You would expect to improve your speech understanding in quiet and in noise, but again, it's not going to be perfect, and certainly not when there's an extraneous amount of noise in the background. You should expect that you'll be less fatigued and less stressed. You should expect that background noise will still be difficult at times. You should expect that multiple talkers and large groups will also be difficult at times as well. The television and the TV, most patients see improvement with this, but it's not always perfect. News channels are often easier than, say, some of the sitcoms where there's 4 or 5 people talking at the same time. And then music appreciation is something you can gain with the cochlear implant as well. And Kelly did a really nice job of telling me before this Tuesday talk started about his experience with gaining music appreciation with a cochlear implant. So these are the expectations you should have. And so when you go into your programming appointment with your audiologist, these are the things that you should be able to say, hey, I'm seeing some improvement in these areas. If you're not, then it definitely, would make the audiologist think maybe there's some things we could do to improve that. So one of the most common questions I get is, why does the cochlear implant not sound natural? Why doesn't it sound like I remember natural sounds to be? Well, so if you think about it, we have a limited amount of space on that electrode that's inside your inner ear. And we're trying to compress all of the low pitch, mid pitch, and high pitch sounds into this very limited space. In your natural ear, you have much more space for all of those sounds to be displayed. And so compressing the sounds into a smaller space is going to make it not sound quite as natural to everyone. But there's a lot of other reasons besides just our anatomy that can come into play. So you can see on the left-hand side pre-implant, and on the right side is post-implant. These are all factors that would make you maybe perform better or worse with a cochlear implant compared to your friend, or maybe compared to someone that you're chatting with on cochlear implant experiences. So the reason I bring this up is because we're all very different. Our stories are very different. Carol and Kelly, while they seem to do very well with their cochlear implants, my guess is if they talk to each other about the intricacies of each expectation they have with an implant, they may have a very different story to tell, because Carol's story is different than Kelly's. And so being careful about how we compare our progress to others is something that is really important throughout this process. While all of these factors can play a role into performance, you know, one of the biggest things that we'll talk about today is programming, and that's from what the audiologist and you have an active part in this as a patient, how that works together to make it the best available option. So when you come in, you've had your surgery, what happens at that first day? Everybody's super nervous. Fortunately, now with the pandemic, with some of the restrictions easing up, you can bring some family members in with you for your appointments. But, you know, I feel like the biggest thing that we want to get out of the initial activation is we want you to leave hearing better than you heard when you came in. Now, hearing and understanding are not the same thing. So anytime I say hearing, that does not mean speech understanding. Many patients say that they can hear the turn signal in their car when they go home from the appointment, which is awesome. If that's the only thing that happens that day, I'm super happy as an audiologist, because it means that your auditory system is recognizing sounds that you didn't hear previously. So when you do come in and get settled, one of the first things that we're going to do as audiologists is look at your incision site. And the reason we do that is to make sure that there is no inflammation, make sure that the incision site is healing well. And then we also want to look at your magnet and try and make sure that the strength is appropriate. And then we discuss realistic expectations. I can't tell you how many times I repeat my realistic expectation talk on the initial activation day. And many patients maybe don't remember exactly that we had that talk before surgery. This is not the same thing, but I had a injury several years ago and tore my ACL in my knee. And my surgeon told me before the surgery that I would be out of commission for several weeks, would probably not run again for over a month. And I truly thought that he was crazy. And when I woke up from surgery and had this massive, contraption on my knee, it was at that moment that I realized, oh, I guess he knew what he was talking about. So realistically, we don't expect you to understand what your spouse is saying that day. We don't expect you to understand your child's voice, and we don't expect you to understand on the telephone the first day. But during the programming of the cochlear implant, what we hope to do is to give you better access to sound so that you do start hearing voices and you start hearing noises. And this is me in a programming session when I was at MUSC. We used to have the programming wall was green. So if I ever see videos online with green walls, I know they're from MUSC where I used to work. But this is something that I would do in initial activation, is try and cover my mouth and see if I could get a patient to understand even simple things like hot dog, ice cream, baseball, or perhaps even just days of the week. Anything that you can recognize that you couldn't recognize before you came in that day is a success. Then counseling on the basics of the cochlear implant equipment. Most of you who have been implanted and activated, I hope you remember that that counseling on the equipment. It's so much stuff. There's boxes of everything, and you probably are thinking, what did I get myself into? Keeping it as basic as possible is not us trying to say that you aren't well equipped to understand what all the equipment is. It's us making sure that you're not completely overwhelmed by this process. You know, we want you to be comfortable, and we want you to feel like you can really go home and take care of your hearing needs without having to learn 75 pieces of equipment in 10 minutes. And then we'll review the follow-up appointment schedule that day so that everyone has an idea of when you're going to be coming in to see us. And I'll go over that follow-up schedule in just a bit, but just know that the reason we have follow-up schedules the way we do is because there's a lot of published literature about levels, and I'll talk about that too, the stimulation levels that we're programming. There's a lot of literature about how often they change and when they start to be stable or plateau. So the follow-up schedule is based on all of that. So when you come back, after you've had a little bit of time of experience, you come back for a follow-up programming appointment. So what should you expect at that appointment? Well, you know, we're going to check your magnet again. Remember, we don't want the magnet to be too strong. If it is, it's going to be causing breakdown of your skin, which is a bad thing. In my clinic, we change the microphone covers every time patients come in if it's needed. It's just part of the appointment. It's a courtesy, and oftentimes it can make a very big difference in the quality of sound that you are picking up with your device. And then a listening check and a visual inspection of the CI processor, I think, is extremely important. I would say if you work with an audiologist who is not doing these things, ask them to start doing them, because I think it's very important that we know before we get into programming that we know that all the equipment's working properly, and you know, that we have the best opportunity for you to perform well in that programming session. So what else should you expect? This is where I think the strengths come in of a good audiologist and patient relationship. There's got to be some discussion. Oftentimes I feel like programming appointments are 10% actual programming and 90% discussion, and trying to make sure that we understand you and that you understand us and what we're trying to do. You know, we want to know what the successes you've had and the struggles you have had. We want to know specific incidents where sound has been difficult for you to hear or speech has been difficult for you to understand. We're also going to continue to discuss realistic expectations. You're going to see that throughout most of these slides. And we're most often going to do testing in the sound booth and CI programming. Now, depending on what site you work with, what clinic you work with or go to, sometimes they will do programming and testing in 2 different appointments. Here at the University of Miami and when I was at the Medical University of South Carolina, we did all of that in the same appointment. I think there's a lot of good information we can get from the testing that can reassure us or help us know that the programming is appropriate. Okay, so how is the CI mapped? How is it programmed? There's a lot of things we can do with programming, but not all of them are done every single time. Here's a list of a few of the things that I tend to use more often in my programming sessions. And I'm going to show you a slide with some screenshots of what these look like. You know, ask your audiologist if you can look at the screen and get used to just watching and knowing what's happening with your programming. I think it's really fun to bring the patient into the appointment and make them a part of it that way. I think it builds a lot of trust, and you know, it's just fun to see what's happening on the computer screen. So the first thing that we do is an impedance check. So what that's doing is providing the status of those individual electrode contacts. So you can see here I have all 3 companies displayed. To the left is Med-El. On the right at the top is Advanced Bionics, and then on the right at the bottom is Cochlear. You can see that each of the companies have different numbers of electrode contacts. And so we're testing each one of those. For cochlears and for advanced bionics, you see two different kind of runs of those impedances. The reason I left that up there is to show you that we can actually compare the response the day that you're in the office, and we can compare it to the last time you were in the office. And what we're looking for is a normal response, which means that the current is flowing through the tissue and the fluid of the cochlea, and that the device is sitting where it's supposed to be and is working appropriately. Sometimes you'll see on Med-L's screen over here, if you can see my mouse, this one little electrode contact is kind of grayed out. And the reason it's grayed out is because during the impedance check, it was picked up that there was a open or a short circuit. And in those situations, you're able to turn those electrode contacts off. Sometimes patients will ask, well, doesn't that ruin the way my device sounds? Isn't it going to mess up the programming in general? And in fact, it doesn't. Really, we just want to make sure that we're presenting sound in the spaces of those contacts where the quality is going to be the best. So if there is something that's abnormal, turning it off actually is to your benefit. We also check data logging. So I've been in this business long enough that data logging is relatively still a new thing. Data logging tells us the number of hours per day that the cochlear implant was used. You can see that there is multiple ways of looking at this. Many years ago, when we were first working in cochlear implants, we couldn't see data logging. So we actually used that screen prior, the impedance screen, to tell us if you were using the device consistently or not. And there were some ways we could look at those changes over time to tell us that. So here I've got screenshots again of all three companies. So the top left is Cochlear, and you can see here, this is at the bottom, you've got October to another session in October to another one in April, and then to today. And it looks like this person has sort of waxed and waned whether they were using the implant consistently. The day that we did the data logging, it shows us that this person was using the device 12.8 hours a day. And then we could also take it a step further and look at how often the patient was in noise, speech and noise, speech, quiet, music, and then loud noise. So all of this information is good for the audiologist to know, because, for example, if Carol tells me, hey, I'm really struggling with speech and noise, but I look at her graph and it shows me that she's never in speech and noise, I would say, well, maybe there's some practicing that we'll need to get you to do, give you some listening homework to try and make that better. I can also look over here on the right-hand side, top right-hand side is advanced bionics. So again, here you can see that this patient really has been working hard over each session to increase the number of hours that they're wearing the device. Taking it even a step further, down below that is advanced bionics again, and it breaks it out into all of the different programs, automatic programs that are used in the new processor called the Marvel. And I can see that this person, 72% of their left ear is being used in a streaming mode. This is actually a 22-year-old who is working remotely, and she is on Zoom almost all of the time that she's using the device. But these tell me a lot of interesting things about the patient. And then likewise over here for the left-hand side for Med-L, I can see how many times the device has been switched on. So 2.9 times that it's switched on per day. Let's say for some reason that was a really high number. I might ask you, hey, well, so why are you cutting it off, turning it on, turning it off so many times? And maybe you're not doing that. Maybe there's something wrong with the equipment, but identifying it based off of these graphs is really important. So one of the questions I get is, do I really need to wear this device all day? I'm home, it's quiet in my house, or, I just don't care about like hearing my cat's fingernails on the floor, or sometimes my husband is in there talking on the phone to the grandkids, and I just want to be quiet. Well, it's really actually very important that the device is used all the time. And so this is a part of the programming that if I see that the patient is not wearing the device all day, we're going to have a very serious conversation. So there's multiple articles that have been written that show that the device use is super important. The clinical recommendation you can see is over 10 hours a day is going to be the best performance with a cochlear implant. Less than 10 hours a day is the worst performance. So the reason I bring this up is because this programming session that you come to with the audiologist, we expect that you guys as the patients are doing your part to optimize your listening in quiet and in noise. And part of that optimization is wearing the device all the time. If I see that patients are not wearing it more than 10 hours a day, but they are very concerned with their performance, my response usually will be, we can talk about further programming once you're wearing it all day, but there is a significant correlation with postoperative cochlear implant speech understanding performance and the number of hours a day that the CI is used. Okay, what about this? I'm sure some of you have seen this screen too, where we've got these crazy looking little bars, or we have these little hash marks or red and green symbols. What we're doing as audiologists is we're setting the upper and the lower stimulation levels. So again, I have all three companies represented here, but pretty much we're doing something very similar with all three. We want soft sounds to be soft. We want medium sounds to be medium, and we want loud sounds to be loud. We don't want soft and medium sounds to be loud, the same as loud sounds. So the same with me, with I have a normal hearing, not quite as normal as it was 10 years ago, but I still need to hear soft speech and loud speech, but I need them to be different in order for my brain to really truly understand what it is I'm listening to and how one sound differs from the other. When we're doing the measurements for lower and upper stimulation levels, the upper stimulation levels are always going to be at the top. And we know as audiologists that there's usually an average range for each company of what those levels should be. Now, not everyone is average, of course. So some may be a little higher, some may be a little lower. But regardless, we want to make sure that the upper stimulation levels are not too loud, but we want them to be loud and comfortable. The lower stimulation levels, conversely, we want those to be very, very, very soft. So each company differs a little bit in their methodology for this. And, for one company, we need to set the T levels or the threshold levels, the lower stimulation levels, where they're completely inaudible, meaning the patient does not hear them at all. For another company, we might set them to where the patient hears them 50% of the time, because that's what the company recommends. And for a third company, it may be that they need to hear them 100% of the time. So depending on which device you have, your audiologist will likely vary in how they are setting those lower stimulation levels. I do have one patient here in Miami. I love him. He has one advanced bionics device and he has one Med-L device. And so it's challenging for me as an audiologist because you have to set each one a little bit differently. And so, your brain has to always be really focusing on which ear that we're working with at which time, because those lower stimulation levels are not going to be set the same way. So this is a little bit of a busy slide, but for the upper levels, there's two ways that we do this. And many of you have maybe experienced both ways, or you may be only one. So the objective way of setting upper levels is something that we call ESRT. And it's using a machine where we put a little probe tip in your ear, and you're going to be hearing a little noise or feeling a little bit of pressure. And then we're going to be transmitting some sound. And the sound is actually causing a reflex inside your ear. So you have a stapedial muscle that's attached to your stapes, which, fun fact, is the smallest bone in your body. And that muscle, if you have a reflex with the muscle being contracted, it can then help us set the upper levels for your loud stimulation levels of a cochlear implant. Now, not everyone has this reflex, so it doesn't work with everyone. And it also is a little bit loud when we have to generate enough sound to cause that reflex to happen. So I do have some patients who can't tolerate this way of programming, but it is something that can be tried. All three companies, their upper stimulation levels do correlate fairly well with that ESRT level. And if it is, it requires extra machines, so not all clinics have that available every time you may be coming in, but it is a nice way of getting some measurements without patients having to tell us what they're hearing. So subjective or behavioral is when you as the patient are telling us what you're hearing. So let's say Kelly is my patient and I say, okay, Kelly, I want you to tell me when the beeping sound, I'm going to make some beeps in your implant. Tell me when the beeping sound gets to be so loud that you want to take it off. And he says, okay, I've got it. And we may even have a graph like you see there, the picture. So that's a nice way to sort of like a pain scale, but it's a loudness scale. And you can tell us when it's very loud, when it's too loud. But we can set each of those upper stimulation levels that way as well. And then we can do something called loudness balancing. So you may have had your audiologist ask you, okay, I'm going to play two different beeping sounds. One's a low pitch, one's a high pitch. You tell me if one of them is louder than the other. The reason we do this is because each of those electrode contacts need to be set at the same volume. If one is louder than the other, then it could be causing you to get too much of one frequency and too little of another. Pitch ranking is another thing that I do very rarely with patients. It is extremely difficult to do. I have my best luck with patients for pitch ranking is those who have recently lost their hearing, like within the past year or two, or patients who have single-sided deafness and really have good pitch perception on the ear that's normal. But pitch ranking would be being able to pick out exactly if, two low pitches, if they sound the same or different in terms of pitch. If you have tinnitus or ringing in your ears, which I'm sure some of you are going to nod about the ringing, it can make pitch ranking extremely difficult. But that is kind of an advanced way of programming an implant. For the lower levels, remember we want them to be super quiet. Typically your audiologist probably will ask you to raise your hand when you hear the beeping sound until you get to the point where you're not hearing it anymore, similar to what we do in the sound booth. And then there's sometimes you may be asked to count the beeps. So maybe you tell them if it's 2, 3, 4, 5 beeps, and they go back and forth until you're getting that right the majority of the time. Both of these ways of setting stimulation levels for upper and for lower are extremely important. And, it does take time and it takes cooperation from the patient. What I will say is these appointments can be definitely very difficult for patients, especially if you're like me. I have a lot of anxiety in general. So I would probably be super anxious if I were a patient wanting to get it right. And there's no right or wrong with setting these levels, but we want you to be as calm and underwhelmed as possible, because we do know that high levels of stress, depression, anxiety, any of those things can play a negative role into how you're able to subjectively report some of these upper and lower levels. Okay, so once we've done all that, with one ear, or maybe if you have 2 ears, like Kelly and Carol do with their implants, then we can actually go into the program settings and we can start making even more adjustments. So Kelly was telling me that as a musician, he actually uses
program settings specific for him to be able to understand music well. And that's great. And he probably must have a great audiologist who is working with him on setting those special settings. But this is where it's really important for you to let us know how you want to use the device, because not everyone wants to use it the same way. And this again is a screenshot from all three companies, just so you can see that if we're working with all three companies as audiologists, it's very different from one to the other. And for a patient in the sound booth, so I put this up here just as an example of a patient I saw recently. On the right-hand side is the audiogram. Hopefully you guys know what this means, but it's low frequency all the way to high frequency at the top. And then very low intensity sounds, so very soft sounds at the -20, and then goes all the way up to maybe a jet engine at 130. So this person has great hearing with their cochlear implant. They're in that 20 to 30 range, which is what I had mentioned previously. And even when I look at their sentence scores and their word scores, you know, it looks like with the right cochlear implant, with these sentences, they're scoring 70% in quiet, 76, and even 70% with some noise in the background. And, you know, I also noticed that the data logging, they're wearing the device a great number of hours a day. So everything seems to be functioning great for this patient. And I, as an audiologist, would look at this and be extremely happy with this performance. But I also know that what I see on my screen and my graph and the numbers that we get from the speech testing do not always equate to satisfaction with a cochlear implant. And so there's got to be a little bit more effort that we go into it instead of just the sound booth. But verifying all of this in the sound booth is a great way for us to have a better discussion with our patients and to talk about realistic expectations again. So what do these scores even mean? So the words, if you, I'm sure you all know these: ready, goose, ready, sees. That man just keeps saying those words over and over. And what we're doing is we're counting whether or not you get the word correct. We're also counting whether or not you get the sounds in the word correct. So you can see the example there, ready, sees. The answer, the person said size, so they only got 2 of the 3 sounds correct. What you may not know is it's not typical that a cochlear implant adult scores 100% on this test. This test is really hard. The only thing you have to go on is 3 sounds that make up a word. That's it. So it's strictly about listening to what you hear and repeating it. 60 to 65% is the score that's for what we typically see for an average adult cochlear implant user. Okay, so if you're getting 60 to 65%, super happy with that. I'm very happy with it because you are at average. Of course, most of you want above average, I'm sure, but this is great. Now, what about the sentences? So I put the pictures of Dr. Dorman and Dr. Spar up here so you all can have visuals next time of the 2 men that are talking on those sentences. You know, one sounds like he has marbles in his mouth, I hear, and the other one just has a very kind of like raspy voice. There's also 2 female talkers. Now, we only really test in quiet and in some noise. And realistically, the noise that we're testing you in is not at all comparable to what you typically are doing in your everyday life. So this is an example here. So let's say the first sentence, I could hear another conversation through the cordless phone. This person only got conversation, through, and phone. So 3 words of the sentence. The score at the bottom represents the percent score for the entire list, which they got 72%. That seems like a great score, but that's in complete silence. And even in the room that I'm in right now, I can hear the humming of an air conditioner. So it's not silent really anywhere that we go. We're moving away towards really putting a lot of emphasis on the sentence scores and putting more emphasis on the word scores, because the sentences really don't tell us a whole lot about how you do in normal everyday life. And in fact, looking at sentences, you know, remember in that first slide I showed you of how the sound has to travel all the way to the brain. Age, cognition, stress, anxiety, depression, you know, maybe you have another appointment that you have to get to right after the appointment with the audiologist and you're just not paying attention. Any of those things are going to play a negative role into the sentence % correct score. The words, it's not going to play as big of a role in. So I don't want you as the patient to get too stressed out over these tests. Audiologists have writing, but I do think to get away from using these sentences and rely mainly on words for performance. And then this is a great graph that I hope you guys can use in your daily life from here on out. So Dr. Dorman and Dr. Gifford, wonderful researchers in the world of cochlear implants. This is from an article that they published in 2017. What I want to point out is NH is someone with normal hearing. So that would be like me. CI is an adult with a cochlear implant. So for those sentences in quiet, AZ Bio sentences in quiet, a normal hearing adult like myself scores around 100%, okay? Someone with a cochlear implant scores on average 80% with that sentence in quiet. Now there's a range, some score better, some score worse, but on average 80%. When we introduce some noise in the background, so the noise is 10 decibels softer than the person talking, that score plummets, right? So look, you've got now your cochlear implant user is at 55%. The normal hearing listener like myself is still at 100%, okay? And then when we have the noise is almost as loud as the person talking, so +5, there's only 5 decibel difference, you can see how much harder it is for someone with a cochlear implant. The reason I show this to you guys is because, you know, this is the reality, and this is what I think we need to do a better job in the field of concentrating on. How do we improve this? The technology is certainly getting better. From a programming standpoint, there's not a lot that we can do as audiologists to make these scores better than what they are. I think with an improvement in the technology itself, we'll see a greater improvement in these scores, but also using the accessories, also being in the same room as the person talking to you. You know, all of those tools that you have that come in your box when you first get activated, the reason they were all invented and given to you as part of your kit is so that the speech scores and noise can improve. And that certainly is what we see with those accessories. So many patients still tell me, I can't hear well in noise, please help, please help. I bring this this picture up just so you know, we can be aware of what kind of noise we're dealing with. So remember, normal conversational speech is 60 decibels, okay? So on this graph, anything that's greater than 60 decibels means it's going to be louder than the person talking. So office noise, inside a car going down the highway, no wonder it's hard sometimes to hear your spouse or your loved ones. Oftentimes the car is noisier than the person talking. Certainly if you get into heavy traffic, out on the side of the street, in a subway, you know, a rock concert, it's going to be extremely difficult for someone with hearing loss. And there's not anything we can do from a programming standpoint to help with that. But understanding the limitations of noise and how we can do best understanding in noise, I think is really helpful. So one thing I wanted to give you guys a tip on that helps me counsel patients, and I think it will help you too, get a sound level meter app on your phone. Neosh makes a great one. That's the one that I have. And so if you're in a restaurant that you love to eat at, and say you and your spouse go every Friday, and maybe you really are struggling in that restaurant setting, I want you to take that app out on your phone and look and see how loud is the noise in the restaurant. So for this example, the noise is at 84 decibels. Remember, you're talking to your spouse at 60 decibels. That means the noise is 20 decibels louder than your spouse's voice. So that's going to be a difficult scenario for you to understand in. There's some kind of processing, the program settings that we will have made sure that we add to your programming for the cochlear implant to make this the best possible listening scenario in those types of environments. But using your accessories, is going to be key for that. But I think knowledge is power. And so the more you as the patient is knowledgeable about what kind of noise levels you're dealing with in your everyday life, and you bring that into your audiologist, it can make for a great conversation. So how do you understand better in noise? Because that's really what the programming, I think patients come in and want me to make these changes so that you can understand better in noise. And I just can't do it all the time. But being very realistic with your expectations. Visual cues, the masks have been horrible for everyone, but especially for people with hearing loss. Advocating for yourself, asking for a table in the back of the restaurant that's more quiet. Getting your friends part of your journey and having them use accessories and make it fun. I've said be realistic with your expectations again, because I think that we have to keep talking about that. Ask for a specific noise setting for your processor. And then really make sure that you and your audiologist talk about how to use that noise setting and when is appropriate. Also consider something for your second ear, your other ear, either a hearing aid or a second cochlear implant. 2 ears are always better than one. And that's one of the biggest things you can do for yourself, is to make sure you have technology on both ears. And then again, be realistic with your expectations. So how can you help me as an audiologist? Carol used to do a great job of this. She'd come to appointments prepared to discuss how she was hearing and performing. She would give me very concrete examples of what was going well and what was not going well. I don't remember if Carol kept a hearing journal, but I had one guy who would email me the day before his appointment, basically a Word document that was his hearing journal from the past 6 months. Wear your device consistently. That's the biggest thing that we can ask of you so that you can do your part in making you as successful as possible. And then make sure your equipment is functioning well. But remember, we are not magicians. Sometimes I feel horribly that I can't make your device sound better than it is. But remember, there's lots of reasons why programming is only one step of this process and one piece of the puzzle. So sometimes I feel like patients will say, well, I just want to come in every month. I want to come in every week. Maybe you can keep tweaking it a little more. American Cochlear Implant Alliance has this great form online that talks about the experience and the postoperative appointments. They actually say on there that annual appointments is necessary. What we're seeing in the field is really after the 1-year appointment, as needed is what's necessary. The research is showing that the upper and lower stimulation levels I talked about, which is really the biggest thing we have access to for programming, they really don't change much after 3 to 6 months of you wearing the device. But what does change is how you use the device. So what about the future? I think in the future, we're going to see more remote programming, potentially where you're at your house and I'm in my clinic. Artificial intelligence, where maybe the device, your processor is picking up how you're using it. And then it, when it syncs to my computer, maybe it automatically changes your settings for you and for me. And then maybe in somewhere in the future, you guys will be programming your own cochlear implants. I'm not sure exactly what that will look like, but I think there's a lot of things coming in the future. I want to just give a brief thank you to my hearing implant team at the University of Miami. Without each of these people, I would not be nearly as even decent at my job as I am. They are wonderful, and I do think it takes a whole village, but you are the center of that village as the patient. And I think we're just here to try to be on your hearing team and to help you hear the best you can. All right, so I think I've only got maybe 10 minutes or so for questions, but I'm going to open the chat, and I know my moderators are helping with that as well.
Meredith, thank you so much for that wonderful presentation. There was so much packed in there. It was so interesting. And I think a lot of questions were answered just during your presentation. I hope so.
I agree. And it reminds me of a conversation I had recently with somebody about cochlear implant technology and programming, and they sort of disparagingly said that it can't be rocket science. And I got to thinking that rocket scientists, they got some mathematics and physics and mechanics, and they know what's going to happen, why it's going to happen, when it's going to happen.
Right.
When you take a human brain and throw it into that mix, it just becomes exponentially more difficult and complex. So I really appreciate the commitment and expertise that a good audiologist like you brings to the table.
Absolutely.
Thank you. I did see one question in the chat that I wanted to bring up. There's a couple of questions about the cochlear implant and the hearing aid together, and how that may work if the hearing aid's on one side and the implant's on the other side, but also how that may work if there's a hybrid, so the cochlear implant and the hearing aid are on the same side. You know, what I'll tell you is there's not a delay necessarily between the two devices. The brain is a really amazing organ, and it acclimates to using acoustic hearing from the hearing aid and the electrical hearing from the cochlear implant. And it combines the information that it gets from those two things to make your understanding even better than just with one device by itself. So if you think about the hearing aid, what it's really providing is better access to low pitch sounds, even the lower pitch sounds that you can't access with the cochlear implant. But the cochlear implant is giving you access to all of those high pitch sounds and mid pitch sounds that the hearing aid is not giving access to. And so the two together combine efforts and make the sound quality much more natural. I have many patients who are still using a hearing aid in one ear and an implant in the other. And they do wear both devices beautifully. And they actually say that the combined hearing in both devices makes it sound more natural than just one by itself. And the same is true if you have a hybrid device, which is the cochlear implant and the hearing aid on the same side.
I have a question here. This is something I talk to people about a lot of times, is every day listening to TV, the radio and speech, the same as using an app, exercises that relate to rehab. And
that is a great question.
Yes.
Yeah. And I think, Deborah, thank you for asking that question. You know, it's not exactly the same thing. So rehab is, you know, I'll say this. I think everybody's opportunity to do rehab can look different. So some people enjoy doing their rehab on the computer or on an app on their phone, and they're listening to voices that they're not familiar with, with words and phrases and sentences. Some people don't like listening that way, and they prefer to have their spouse or their grandchild or maybe their child or their neighbor come over and read from the newspaper so that they can get acclimated to a voice that they're used to. Other patients, maybe some who live alone and don't have access to all of those technologies or the neighbors or the family, they prefer to use the television. And honestly, in my opinion, as long as you are getting stimulation, which means talking and noises and sounds, into your cochlear implant, it's strengthening your brain's ability to listen and interpret your cochlear implant's sound. So whatever you choose, we just want you to be doing something on your own therapy for your ear. And therapy looks different for everyone. There are some speech language pathologists out there who are willing to see adults in their office to do therapy. And there are also some who will do it remotely, like via Zoom, the way we're talking right now, except you would be able to see them. And many insurance companies will pay for that. So I would encourage you to think about if that is an option for you, try that. Otherwise, the TV is great. And also the apps on the phone from all three of the companies are great as well.
So this is something that's near and dear to my heart. I would love to hear Kelly and Carol describe their experiences with music.
Yes, please do.
My experience with music was when I first got activated, music was unrecognizable noise. I had zero pitch perception. I would play scales on my guitar and it would sound like the same note repeated over and over again. I had some beginning programming that had a lot of noise suppression on it. The louder I played my guitar, the quieter it became, and I could not understand what music was. So my audiologist gave me some open programs, had all the noise suppression and auto compression and auto gain turned off. They were loud and abrasive, every night I would play scales on my guitar, and things slowly came around, and pitch intervals started making steps, and I just religiously played. And now I am back to playing music. I got implanted a year and a half or so ago, and I'm back to playing music. It sounds different than it did as my in my memories of it from back when I could hear good, but it is far better than I expected to hear with cochlear implants, and it gets better continuously. I can see slow, steady progress the more that I play, and the more I put myself into complex, challenging situations, the better pitch perception and music sounds. So don't let that hold you back from getting a cochlear implant. It was a huge, huge decision for me to make the jump to cochlear implants, but I am so glad I did.
Yeah, that's amazing, Kelly. I'm not a musician, but I've always loved music. And as I started losing my hearing during my 20s and 30s and beyond, I was missing it, and I was missing it a lot. Music sounded distorted. I couldn't tell the song. I couldn't tell the artist. I couldn't tell anything. I just heard basically noise, and it was awful, and it was sad for me. With my first cochlear implant, this was a long time ago, a couple of generations of implant processors ago, it started getting better, but basically it was up to me to practice. And by practicing, I would pick a simple song with a simple melody and maybe just one singer. And I would play it over and over and over and over. And eventually it started seeping into my little pea brain, and eureka, I could understand it better. And it didn't get even better. Improvements didn't happen unless I practiced more and challenged myself to listen to more complex music and just keep at it. But with my current processors, which are the Marvels, I have Bluetooth, and music is coming in better than ever. And I'm hearing and understanding music, and I recognize music that is familiar to me. And, you know, I'm thrilled with it.
So I got another one. How long did I have to work at it before it went from noise to pitch recognition? And that I got my left ear implanted first, and it was just strange, robotic, alien robots for a couple months. About 2 or 3 months in, I had a big change in pitch perception, and voices dropped down to normal. That was one big breakthrough moment for me that I'll never forget. When that happened, I got bilaterally implanted because I saw the advantages of cochlear implants. So it was about 6 months after going bilateral, I got a programming map session. And when I got home, I stepped out of my truck and I could hear things off in the distance that were supposed to be off in the distance. I could hear the chickens clucking around in the yard. Everything sounded like it was out in the real world where it was supposed to be instead of coming from inside my head. And from that moment on, once I started playing guitar that night, I saw a drastic improvement in my pitch perception. You know, scales started stepping along, stepping up when I played up and stepping down when I played down. And it's just been a gradual improvement, constant improvement since then. So that encouraged me because I saw that big improvement, and it just encourages me to play every day. And I think guitars are the finest rehab tool available on this planet. You can feel the vibrations, you can watch your hands and get that motor skill. You can feel the pitch, and it just helps out so much to have some other information besides auditory that to recognize pitch.
You know, Kelly, I think one of the things you mentioned, though, is so important. You mentioned practicing, and
Yes.
you mentioned that you did it every night. and that you were dedicated to the process of it getting better. And I think that is one of the biggest take-home messages for these cochlear implants, is that it is a process. It's going to take a lot of time and dedication and practice, but somebody like you who was determined for that music to be better or speech understanding to be better, you were willing to put in the work yourself, which is amazing.
It takes a tremendous amount of effort. And I think that by using music and gaining pitch perception, it not just helps your music appreciation, but it helps out identifying people's voice, the difference between people's voices, and it helps out telling emotion in people's voices and making environmental noises sound like they are what they are. It's just, it's not just for music appreciation. It helps out every aspect.
That's right. There's a lot of environmental sounds that I was missing as I was losing my hearing. Bird song was one of them. And I grieved the loss of hearing birds when I was outside. I could see birds. I could see their little mouses, the mouse peeping, but it was silent. It was silent. And I was really sad about that. So it wasn't for maybe 6 months or so after my first CI in 2010 that I started hearing little scratchy sounds. And I asked my husband, what the heck is that? And he said, oh, that's the birds in the bushes over there. I said, you're kidding. That's a bird. And it was so emotional for me. I started crying. I lost it. And it was just better and better after that. I started hearing more things. I heard all the beeps like the microwave and my turn signal. And eventually my brain caught on to what sound it was that I was listening to, and just trial and error, ask questions, listen, just practice and practice. Eventually it came through.
The hearing and noise too. The hearing and noise for me, I don't know. Once I got these open programs for music, they have just become my everyday listening programs. I don't use any sound suppression or auto gain or auto compression on. I just listen to everything and let my brain sort it out. And hearing and noise is a thing that you have to practice also. So I put myself into complex, noisy situations and just let my brain figure out what's going on and start tracking speech. And that is another listening rehabilitation. You don't avoid noisy situations. You go into them with your eyes open, knowing it's going to be challenging, and just try to make the best of it. But it's all a work in progress, and you have to work at it every day.
That's right. You have to challenge yourself. It's been hard during the pandemic when so many of us have been isolated and not going out in the public. We just have to keep challenging ourselves and keep practicing and practicing and listening as much as we can in every kind of a situation.
Yep. So Meredith, do you know Kara?
I do. Yes, I do.
Kara is my superhero. So she's fantastic.
Yeah.
I love that. You know, there's so many good audiologists out there, and you know, we appreciate, as audiologists, we appreciate all of you patients who come in and really want to work with us, and we appreciate your time and your devotion to this whole process. I also really appreciate all of you being here today to hear this talk and to learn from Kelly and from Carol. They're really the experts on cochlear implants, not me, because they live with cochlear implants every day. And I also appreciate that you guys are here to learn more about the American Cochlear Implant Alliance. This is just one of a series, one in a series of the Tuesday talks. They're all going to be posted on the Alliance webpage in the coming weeks. And remember, it was recorded, so you can watch it back if you want. And then I don't know if anybody from the Alliance has anything they wanted to say, or maybe we can say goodbye.
Thank you so much, Meredith. I saw all the great comments in the chat from everyone about the information and how we need to do this more often. So hopefully we will. And I just want to echo Meredith and say thank you to everyone who came on. Thank you to Kelly and to Carol. We'll post this all on the website, and we appreciate you all coming on and staying with us late. Thank you so much.
You're
Thank
welcome.
you.
My pleasure.
Thank you. It was enjoyable.
Yes,
Thanks.
really. Nice to see your smiling faces.